Hello and welcome to the EBA and ESA Task Force lectures on patient safety. These lectures are basic lectures on various topics of patient safety and are brought to you by the members of the Task Force Patient Safety of the European Board and European Society of Anesthesiology. Members of the task force are Guttorm Brattebø from Norway and Andrew Fairley-Smith and David Whittaker from the United Kingdom. The task force is chaired by Sven Stender from Switzerland. The topic of today is patient safety, past, present and future. This lecture is presented to you by Sven Stender, Task Force Patient Safety. In this lecture we will discuss safety aspects in medicine in general. We will look at the milestone publications of the Institute of Medicine in 1999 and will take a look what this publication has triggered. The second part of this lecture will evaluate where medicine has reached up in selected safety aspects 5 years later, and we will conclude with an evaluation of general patient safety numbers today. We must face the fact that we take risk in daily life, not only in medicine but in general every day. This cartoon is not only funny. It shows some interesting aspects that we easily can transform into medicine. Take a look at these workers. They come to work in the morning and they are confronted with a very difficult task: to move this machine up into the upper floor. To fulfill the request by their boss, they take a very risky approach, but they simply do not seek the risk. They simply want to do their best job to fulfill the task given to them. They do not come to work and say, "Ooh, today we are doing something completely crazy." They are challenged, they are motivated, and they find a solution, at last a risky one. The same goes true for medicine. The vast majority of our colleagues go to work in the morning and want to do their best job that day. They are challenged by an unusual situation and they find ways to solve that problem, and sometimes they take a huge risk. Sometimes we do make mistakes, and quite frequently these mistakes are somehow related to human behavior, like having the wrong mental model of a certain situation, as for example in this picture. Having said all that, we have been faced by a cornerstone publication of the Institute of Medicine in 1999. The IOM published data on adverse events in US hospitals and came to the shocking result of nearly 100,000 deaths patients annually in the United States due to adverse events. Compared to other industries, these numbers of losses would correspond to about one major aircraft crash every second day. These findings from the United States have been corroborated by the National Health Service in the United Kingdom. In their year 2000 report named An Organization with a Memory, the NHS calculated around 400 deaths of seriously injured patients per year due to adverse events. They calculated to face about 850,000 admissions per year that experience a harmful adverse event. These losses consuming huge financial resources, £2 billion per year of direct cost of additional days in hospital due to adverse events, £400 million per year for settlement of claims, and £1 billion of cost per year for hospital-acquired infections. Compared to other causes of death, the high estimate of the Institute of Medicine numbers equals a death rate that would mean that medical errors were the 5th leading cause of death in the United States in these days, more frequent than death from road accidents or from diabetes. The publication of the IOM report triggered a huge number of activities. Safety-related publications and research on that topic increased nearly exponentially after the year 1999. The same was true for safety publications in anesthesia and intensive care medicine, although it looks like we have increased our interest in that topic already some 5 years before this IOM report, at least in anesthesiology. But not only publications increased. In the United States, Large national campaigns on safety and learning have been launched, and patient safety organizations and foundations evolved all over the Western world. Five years after that important report of the IOM, two of the pioneers in that field, Lucian Lepi and Don Berwick, resumed about what we have learned until then. They concluded that change was noticeable in a variety of aspects, like viewing the problem. Away from asking whether there is a problem at all to what can we do about it, from chasing the bad apple to searching for the bad system. They found a much broader stakeholder support and noticed a change in practice in aspects like medication safety, patient identification, human factors, communication, crew resource management, adverse event handling, incident reporting, and root cause analysis. This early enthusiasm led them to announce goals that should be reached by the year 2009, that would be 10 years after the IOM report. These requirements were a 90% reduction in nosocomial infections, a 50% reduction in medication error, and a 100% elimination of never events. Never events are events that really should have an occurrence of zero. Events like wrong side surgery, death due to transfusion error, or giving newborns to the wrong parents. They were very enthusiastic these days and wrote, "The primary obstacles to achieving these results are no longer technical. The obstacles lie in beliefs, intentions, cultures, and choices. We will not become safe until we choose to become safe." When we evaluate patient safety today, that is more than 10 years after the publication of the IOM report, we will find the following. Concerning a 90% reduction in nosocomial infections, we must admit that nosocomial infections were the topic of more than 500 publications in Medline only in the year 2010. Or what about a 50% reduction in medication error? Today we still have a big threat by medication errors. The numbers lay around in about 300 or 1 in about 500 anesthetics given. This is also true for anesthesiology, where we still have articles like that one, "Fatal Errors in Nitrous Oxide Delivery," a publication in Anesthesia from 2007. That led to an editorial which concluded that recurrent wrong drug error is a professional shame. But how about the really big catastrophes, the required 100% elimination of the never events? Let's look only at the today's rate of wrong side surgery as one of the so-called never events. The Journal of Bone and Joint Surgery reported on a 5.6% rate of wrong side surgery in a study published in 2009. The Archives of Surgery published the number of 342 cases of incorrect surgical procedures in Veterans Affairs hospitals in 2009, with no standardization, timeout problems, and communication problems being the majority of root causes of these events. But also in anesthesiology we face wrong side procedures, like this publication's reporting on wrong side pain procedures. Interestingly, these cases occurred even despite marking of the site and performing a team timeout. This concept of team timeout comes from an important campaign of the World Health Organization, who requested a team timeout immediately before starting the procedure, checking on the very last occasion the correct patient, the correct procedure and site, as well as technical aspects of that operation. Performing this very simple checklist led to a substantial reduction in the number of complications, the number of patients with more than one complication, and even a reduction Summing up all these findings, Alan Aitken had once published an unchanged pattern of error over the years, with inadequate patient evaluation and preparation, wrong choice of drugs or technique, inadvertent drug overdose, insufficient crisis management, and insufficient treatment of complications. Ten years after the IOM report, publications like this one from Sweden found a nearly identical rate of adverse events, avoidable harm and mortality, leading to an extensive human suffering and consummation of resources. Landrigan and co-workers did a longitudinal study and published their findings in the New England Journal of Medicine in 2010. They found that preventable harms and high-severity harms were frequent and, most importantly, did not change in trend over the years. Taking into account all that has been said up to now, a 5.6% wrong side surgery rate, Veterans Affairs hospitals reporting of more than 300 cases, wrong side pain procedures, the publication from Sweden with 12% adverse events and 3% mortality rates, and the North Carolina study with 25% adverse events. Let me ask you, would you fly air medicine? Taking into account all that has been said up to now, a 5.6% wrong side surgery rate. This in conclusion led Lucian Leape to write an article in 2009 beginning his statements with the sentence, "Healthcare is unsafe." In that same issue of the journal Quality and Safety in Healthcare, the editor-in-chief wrote an editorial on that problem and stated, "Safe healthcare, we're running out of excuses." What are the barriers today? Why is there nearly no improvement in safety today compared to 10 years earlier? When we, for example, compare with an ultra-safe industry like aviation, we face one distinct difference when it comes to safety management. In healthcare, we are required to talk about cost effectiveness, to argument about usefulness or efficiency when we want to introduce a new technology. In aviation, the criterion is much more simple when innovations are considered. Safety first. If we in healthcare would adopt this approach of safety first, it would have a remarkable effect on different stakeholders. The public would need to know it costs money. The politicians must be aware that it needs resources. The universities would need to change the content of their teaching, and we as clinicians would have to adopt safety as an attitude. So why is healthcare not safer today? One of the aspects that has to be considered is the complexity of today's medicine. Older and older patients with a number of comorbidities are presenting for high-risk surgery. Our individual professional autonomy, the lack of commitment on the top level, and last but not least, the lack of easy-to-trace indicators that would show us progress or standstill in our struggle for safety. Finally, we must keep in mind that safety is not simply absence of error. Safety also is not simply being done by implementing incident reporting or checklists. Safety is a mindset. And repeating the statement of the editor-in-chief of the journal Quality and Safety in Healthcare, we must conclude that it is time to change now. We cannot wait for the next generation.